My channel. Today, I am going to discuss some very important topics from pediatrics that include the sudden infant death syndrome, also called SIDS, the BRUE, that is brief, resolved, unexplained events, and the congenital heart disease topic that include the cyanotic heart disease and the acyanotic heart disease. All right, so let's start. The first topic I am going to cover today from Toronto Notes, Volume 2025 PDF, offline version that I got from the Telegram group, is Sudden Infant Death Syndrome. First of all, the definition of sudden infant death syndrome, that means sudden, as the name shows, an unexpected death of an infant less than 12 months in which the cause of death cannot be found by history, examination, or a thorough postmortem and death scene investigation. All right. So it means to say that there is a sudden, unexplained death of the infant. Infant is always less than 12-month old, and the cause of death we cannot find it. Either by history means unknown cause of death is there. Either history is not suggestive of the cause of death, examination findings are not suggestive, or even the post-mortem examination and also the death scene investigations, they do not give us the clue of the cause of death. So means to say the cause of death is not known. Etiology, what can be the etiology, what can be the causative agents that can lead to such thing? Inherently unknown, but affected infants appear to have: number one, underlying genetic or anatomical conditions, for example brainstem abnormality. All right, as the name shows, as we already read in the definition, that the cause of death is not known, but some causes can be that the child, or sorry, not a child, the infant who is less than 12 months old, that may be having some underlying genetic, chromosomal, or anatomical conditions, for example, some abnormalities of the brainstem, predisposition, and anatomic predisposition, and a trigger event, for example, maternal smoking, airflow obstruction, which simultaneously occur during a vulnerable stage of development. All right. That makes sense now that the cause, although is unknown, but there are certain factors that can lead to this. Some genetic conditions, the chromosomal conditions, the neurodevelopmental disorders, anatomical disorders, and some triggers. Maybe maternal smoking is linked with it, or maybe sudden obstruction of airways, maybe choking episode or something like that. That can lead to it. Okay. Now, most deaths occur between midnight and 8 a.m. Very important, means crucial time, midnight to 8 a.m. Okay, so more common in children placed in prone position. That's why we always recommend moms, new moms, to sleep their infants in always in a supine position, not in the prone position. Okay, in the case of full-term infants, peak incidence is 2 to 4 months, and by 6 months, 94% cases can happen. Okay, even increase in deaths occur during respiratory seasonal virus. Okay, the flu season, the respiratory syncytial virus, the flu season. So basically, the infants have basically very small airways, right? So if they have so much like fluid virus infections, that can lead to blocking of airways and can lead to death of the child. So with that, this factor we should always keep in mind. All right, other risk factors include basically the maternal risk factors. Maternal means factors which are basically related to mom, like very young age, less than 20 years, smoking, alcohol, drug abuse, late or no prenatal care. Means if the mom was not having excellent prenatal care services at her disposal, if the mom was having drug abuse symptoms, no, if she's an addict, if she's an alcoholic, cigarette smoker, and drug abuser, especially she does all these things during pregnancy, especially, or if she is quite young, like less than 20 years. Then some infant factors that we also should keep in our mind, that may include prematurity. If the child is born before 37 weeks of gestation, that is known as a premature child. Low birth weight. Normal birth weight is almost 2.5 pounds, and now is the low birth weight means less than that. Prone sleeping position. If the child has a habit of sleeping always in a prone position. Soft bedding, that is sleeping on soft surface or with blankets and pillows, that's very important. In winter season, in flu season, especially in Canada, the new moms, they are very much scared of the cold weather, the snowy, chilly weather. They want to keep their children safe. And for that purpose, sometimes they wrap their children in so many blankets. I have personally seen such moms who wrap their children in many blankets, and even when the child is sleeping, sometimes these blankets can tangle around his mouth and can suffocate the child. So that's why it's always said that we should avoid very soft bedding for the infant, and sleeping on a very soft surface with lots of blankets and pillows. So it's recommended that the child should always sleep in a supine position without any blanket, on a bit medium soft surface, not very soft, and spine position, and make sure that the face of the child or the nose of the child is not covered with blanket or not blocked by pillow. Siblings of a SIDS victim means it's may run in families, that if there is a child whose sibling also was a victim of SIDS, so that there is 5 to 6 times increased risk of SIDS. The what can be the reason here? That of course some environmental factors could be there, some social factors, some caregiver factors, all these things can. So if it happens for the first time, it can happen again in the other siblings as well. Environmental factors that we need to keep in mind. Exposure to second-hand smoke. Look, smoking is extremely dangerous to the infant, so that's why it's recommended never ever smoke in the same room where the child is sleeping. So second-hand smoke, that is the first-hand smoke, right? But the second-hand smoke means that if someone has smoke outside the room, outside the building, but with those same clothes and with same dress wearing, the person comes back in the room where the child is sleeping, or the child is having rest, and so the child is getting a second hand smoke. That can also be the risk factor. Bed sharing, co-sleeping is also not recommended here, because sometimes moms and dads, they accidentally can suffocate the child while they are sleeping. That's why we ask parents to arrange special cribs or special separate beds for the child. Overheating, do not overheat the child, and swaddling in a way that can suffocate the child. Or we already talked about it. Then prevention, prevention is always better than cure. So back to sleep, front to play. When a child is sleeping, always put it on the supine position, and front to play. Play infant on the back when sleeping, and daily supervised play or tummy time in prone position. Sometimes we ask infants to put in the prone position while they are playing. That is also called a tummy time. That can help in development of muscles of the child and give, so it's good or beneficial for the child. Avoid sharing bed with infant. So co-sleeping not recommended. Avoid tobacco smoke exposure. Secondhand smoke not recommended. Avoid overheating and overdressing. We don't need to suffocate the child. Appropriate infant bedding like firm mattress. Avoid loose bedding, pillows, stuffed animals, and crib bumper pads. Okay, very important. We all have to avoid all these things. Exclusive breastfeeding in first month, and no smoking. No smoking is very good. Pacifiers appear to have a protective effect. Do not reinsert if falls out during sleep. Sometimes pacifiers they can have protective effect because if the child is sucking and sleeping, so it means that the airways are open. But we don't have to reinsert it all the time whenever it falls off. Infant monitors do not reduce incidence. Immunizations appear to have a protective effect. Alright, the next topic I want to read today is BRUE. We saw in the MCC objectives, QE1 objectives, that was a topic called BRUE. So these are sudden, brief, less than 1 minute, and now resolved episodes in an infant with one or more of the following. So maybe number one, cyanosis or pallor, absent, decreased, or irregular breathing. So these are basically sudden, less than 1 minute episodes that happen in infant less than 12 months old. And maybe there's a cyanosis, cyanotic spells, pallor spells, acyanotic spells, absent, decreased, irregular breathing, absent, decreased, or irregular breathing, changes in the tone or altered level of consciousness. So all these things happens if less than 1 minute and resolve on their own. They are called BRUE. There may be cyanotic spells, the pallor spells, the breathing problems, the changes in the tone of the child, altered level of consciousness. The child should be asymptomatic on presentation because it happened only for 1 minute, and when the child is brought by the parents to the hospital, he should be asymptomatic by now. Evaluation for a cause of BRUE, for example, if there is any ongoing infection, cardiac heart abnormalities, neurological abnormalities, child abuse, metabolic diseases, and toxins. Child abuse, metabolic conditions, and toxins guided by history, examination, observation, and targeted investigation. History, examination, and investigations all are very important. All right. Now, next thing that we are going to read today is congenital heart disease. Congenital heart disease is a very important topic, and therefore we'll spend some time with it. And by any chance, if you guys don't understand it, I recommend you guys to pause the video and take it slow. All right, or keep listening to the lecture again and again to develop a good understanding of this topic. I know it's a little bit tricky topic that we need to remember some things, but I try to make it easy and palatable as possible. Now, congenital heart disease. Okay, here's anatomy. Prenatal anatomy is there. I don't like anatomy. Let's skip it for now. Okay, then the here is what you see. Fetal circulation is designed so that oxygenated blood is preferentially delivered to the brain and myocardium. Makes sense. Alright, guys, so fetal circulation is designed in such a way that oxygenated blood is always provided to the brain and the developing myocardium. Right. So, what happens before birth? Shunting deoxygenated blood and shunting oxygenated blood. Alright. What is shunting deoxygenated blood? Who does that? Ductus arteriosus does that. So remember, deoxygenated ductus arteriosus. What is ductus arteriosus? That is basically a connection between pulmonary artery and aorta. Ductus arteriosus is the connection between aorta and the pulmonary trunk and carries deoxygenated blood. Thank you. Now the second thing, what is shunting oxygenated blood? Foramen ovale, connection between the right side of the heart and left side of the heart. That is connection between the right and the left atria. Foramen ovale is basically a small foramen between the right and left atrium, and that basically serves as a connection. Then the ductus venosus, connection between the umbilical vein and inferior vena cava. So foramen ovale is connection between the basically right and left atria. Ovale between the atria. Ovale atria. Ovale atria. Remember, ovale atria. Between the right and left atria, there is foramen ovale. Now, the ductus venosus connection between umbilical vein and inferior vena cava. Two big names: umbilical vein and inferior vena cava. And the vein is called ductus venosus. What is ductus venosus? Ductus venosus is connection between umbilical vein and inferior vena cava. All right, next thing. Now we read at birth what happens. At birth, with first breath, lungs open up, pulmonary resistance decreases, pulmonic blood flow increases. So when a child is born, in the first breath and the first cry and the first breath, lungs basically expand. Pulmonary resistance decreases. Pulmonic blood flow increases. Separation of low resistance placenta. Systemic circulation becomes a high resistance system. Sorry, guys. So, what they tell us that whenever the child is born and he takes his first breath, what happens? The pulmonary resistance basically decreases, and the lung blood flow increases. All right. Then we have to separate the low resistance placenta. Systemic circulation becomes a high resistance system, and the ductus venosus basically need to close. So ductus venosus, that was a connection between umbilical vein and inferior vena cava. Remember, guys, I told you umbilical vein inferior vena cava connection ductus venosus closes because of separation of placenta. Okay, increased pulmonic flow, increased left atrial pressure, foramen ovale closes. Alright, the foramen ovale is first present between the left and the right atria during the, I'm talking about the fetal circulation. So, what happens that whenever the lung flow increases, increased left atrial pressure, okay, so the foramen ovale closure. Increased oxygen concentration in blood after first breath, sorry. So increased oxygen concentration whenever the first breath happens, that there is increased oxygenation in the blood, decreased prostaglandins and ductus arteriosus closure. So remember, all these fetal blood vessels need to close, ductus venosus need to close, foramen ovale close, and now the ductus arteriosus closure, which is connection between aorta and the pulmonary trunk, guys, don't forget it. All right, now up to now we have read about three things and how they close with the first breath soon after the birth of the child. All right, first there is closure, ductus venosus closure, they told us, then the foramen ovale closure, they told us, then they're talking about ductus arteriosus closure. Closure of fetal shunts and changes in vascular resistance. Infant circulation assumes normal adult flow. Okay, all these things, three steps are very much important for normal adult circulation to start functioning at its optimum, right? So all these shunts need to close, and the changes in the resistance lead to infant circulation assumes normal adult flow. All right. So, basically, 8 in 1000 live births have congenital heart diseases, which may present as a heart murmur, okay, heart failure, or cyanosis. So, most common lesion is the VSD. Okay, then next thing we need to read that, okay, investigations. Echo we need to perform on the child with suspicion of congenital heart disease, ECG of course, and chest x-ray. Pre and post ductal oxygen saturations. Okay, by any method if we can measure the oxygen saturation pre-ductal and post-ductal, that is important. And four limb blood pressure means two upper limbs and two lower limbs. We are basically going to check blood pressure in all four limbs. Hyperoxia test. Okay, whatever the test is, I don't think it's very much important. Just remember that for fetal circulation, we need to, if there's any congenital heart disease suspicion, we need to do these investigations. All right. Okay, and some examinations. Okay, all right. Cyanotic versus acyanotic congenital heart disease. Now is the main topic, right, guys? So let's read it. Cyanosis, or everybody of us know what is cyanosis. Cyanosis means blue. So the blue mucous membranes, nail beds, and skin secondary to an absolute concentration of deoxygenated hemoglobin, 30 gram per liter. Sorry, deciliter. Basically, cyanotic heart disease involves deoxygenated blood, hemoglobin rise. Hemoglobin, which is deoxygenated hemoglobin, it can be at least 30 gram per deciliter. As a result of that, there will be bluish discoloration of the mucous membranes, the nail beds, and the skin. Bluish discoloration of the mucous membranes, इसके अलावा nail bed and basically skin, secondary to an absolute concentration of deoxygenated hemoglobin. Then acyanotic congenital heart disease, that is left to right shunt, obstruction occurs beyond lungs, blood passes through pulmonic circulation, oxygenation takes place, low levels of deoxygenated blood. So no cyanosis. Alright. So whole mechanism we don't need to remember, just remember the cyanosis. Then there is a bluish discoloration and the skin is basically blue because of deoxygenated hemoglobin. Acyanotic heart disease, blood passes through the lung circulation and gets oxygenation, and there's basically no oxygenation, no, there will be oxygenation present, and then it's called acyanotic heart disease. Then cyanotic heart disease. Cyanotic heart disease. Acyanotic heart disease. Now again talk about cyanotic heart disease means right to left shunt. So remember, cyanotic right to left shunt, acyanotic left to right shunt. So we, most of the people in the world, are mostly right-handed, right? So cyanosis. So most people in the world are right-handed. So if there is a shunt from the right side to the left side, so the first condition can happen, that is cyanotic heart disease. Okay, that is known as cyanotic heart disease. That is right to left shunt. Always remember, right side, right-handed cyanosis. Acyanotic left to right shunt. So it means to say blood bypasses the lungs. Okay, no oxygenation occur. High levels of deoxygenated hemoglobin and cyanosis happen. Acha, basically what happens that high levels of deoxygenated hemoglobin enter systemic circulation. Okay, basically what happens that high levels of deoxygenated hemoglobin enter circulation and there will be cyanosis. Okay, characteristic of X-ray findings in congenital heart disease. Acyanotic, cyanotic. Acyanotic, always remember left to right shunt, cyanotic, right to left shunt. So findings on X-ray, that is important. It can occur in MCQs. Boot-shaped heart, off and tricuspid atresia. So BTT, B, boot-shaped heart, T, tetralogy of Fallot and tricuspid atresia. Okay, just say BTT. Okay, don't say anything else. Just say BTTT. So basically, boot-shaped heart happens in tetralogy of Fallot, tricuspid atresia. X-shaped heart, transposition of great artery TGA. So X-shaped heart is TGA. TGA, and boot-shaped heart is tetralogy of Fallot and transposition of tricuspid atresia. So X-shaped heart, transposition of great artery, Snowman heart, total anomalous pulmonary venous return, TAPPVR, total anomalous pulmonary venous return. So there are three main X-ray findings that are very much important to remember for MCQ's point of view, they can give you a very good hint to solve the MCQ. One is the boot-shaped heart. Always remember, the boot-shaped heart is BTT, tetralogy of Fallot, and the next thing is tricuspid atresia. Tetralogy of Fallot and tricuspid atresia, BTD. Okay, and the next thing is X-shaped heart. X-shaped heart basically happens in transposition of great vessels, TGA. Then the snowman heart is basically total anomalous pulmonary venous retention PVR. Alright guys, now there's a very good table here that shows the types of cyanotic and acyanotic heart diseases. So the cyanotic heart disease, as we already said, it has right to left shunt and has 5 T lesions. So I am reading cyanotic heart disease first. So it is basically right to left shunt and it has basically T lesions. Tetralogy of Fallot, Epstein anomaly. Others include TTT. There are 5 T's. Yes. Transposition of great arteries. Truncus arteriosus, total anomaly, pulmonary venous return, tricuspid atresia, hypoplastic left heart syndrome. Alright, so tetralogy of Fallot and transposition of greater TTT. There are 5 T's basically. One is tetralogy of Fallot. Next is transposition of great arteries. Next is truncus arteriosus, total anomalous 1, 2, 3. Total anomalous pulmonary 4 and tricuspid atresia 5. And 2 extra things are hypoplastic left heart syndrome and Epstein anomaly. All these are cyanotic lesions or 5T lesion along with Epstein's anomaly and hypoplastic left heart syndrome. So all these names are very important for MCQ point of view. Next thing is acyanotic heart disease, in which there is a left to right shunt. Alright, and the causes are ASC, atrial septal defect, VSD, ventricular septal defect, and PDA. PDA, these are patent ductus arteriosus, that is the main. So, and atrial septal defect, ventricular septal defect, and PDA. What is that? Atrial septal defect. At least remember these 3 mains called atrial septal defect, ventricular septal defect, and PDA. AV septicular defect, atrioventricular septal defect, endocardial cushion defect, coarctation of aorta, aortic stenosis, and pulmonic stenosis. Alright, so for cyanotic part, we need to remember 5 T's: Epstein anomaly, hypoplastic left heart syndrome. Alright, for acyanotic, we need to remember atrial septal defect, ventricular septal defect, coarctation of aorta, atrioventricular septal defect, and PDA, patent ductus arteriosus. Then aortic stenosis and pulmonary stenosis. So we can combine aortic and pulmonary stenosis. We can combine patent ductus arteriosus with coarctation of aorta, and we can combine ASD and VSD. So these are basically 3 groups of things: ASD, VSD, and AVSD. First group. Second group includes patent ductus arteriosus and coarctation of aorta, and the third group includes aortic stenosis and the pulmonary stenosis. Alright, now let's talk a bit more details about these acyanotic heart conditions first, in which there is definitely the left to right shunting is there. I will not go into the pathophysiology and everything, just read the main things. So just give a good read. Extra blood is displayed through a communication from the left to the right side of the heart. Therefore, it is known as left to right shunt. Increased pulmonary blood flow, increased pulmonary pressure. So whenever such shunt is there, there will be increase in the pulmonary blood flow and there will be increased in the pulmonary pressures. Shunt volume is dependent upon 3 factors: size of defect, pressure gradient, and the peripheral outflow resistance. Untreated shunts can result in pulmonary vascular disease, left ventricular dilatation and dysfunction, right ventricular hypertension, and right ventricular hypertrophy, and right to left shunts ultimately. We don't need to remember all these things, just read about ASD. ASD, that is, they are talking. So, guys, do you remember what is ASD? Is a cyanotic heart disease or acyanotic heart disease? ASD is a acyanotic heart disease, right? So, acyanotic heart disease is ASD. ASD is defect in the formation of interatrial septum. The septum that is present between the left and the right atria, that is not formed properly, and there is a defect. The three types are ostium primum, ostium secundum, and sinus venosus. Ostium primum, ostium secundum, and sinus venosus. So these are basically important for USMLE step 1, or basically anatomy is not very much important for QE1 exam. So we need to just remember the names. Ostium primum, common in DS, defect located at the mitral or tricuspid valve. Ostium secundum, okay, and sinus venosus. Okay, next thing is natural history. 80 to 100% spontaneous closure rate if AST is less than 8 millimeter. That is important to know. So if the ASD ka size of ASD, if it is a size of ASD less than 8 millimeter, it will close spontaneously 80 to 100% of the cases. That's a good thing. If remains patent, congestive heart failure and pulmonary hypertension can develop. If the septal defect does not get closed, then can lead to congestive heart failure and pulmonary hypertension. Clinical features, they are very important that we need to know. Okay, clinical features of first history often asymptomatic in childhood. Physical examination grade 2 by 2 3 or by 6 pulmonic outflow murmur, wide split and fixed S2. So there will be fixed splitting of S2, and there is a pulmonic outflow murmur. Fixed splitting of S2 and pulmonic murmur. So I repeat again, ASD is wide split. So fixed splitting of S2, fixed splitting of S2 along with pulmonic outflow murmur. Children with large ASDs, the size more than 8 millimeter, may have signs of heart failure, means tachypnea, increased respiratory rate, failure to thrive, hepatomegaly, pulmonary rales or retraction. So there will be lung problems, heart problems, liver problems, failure to thrive. All these things are basically the size is really big, and large ASD is there. Investigation, of course, ECG. ECG, we will see right axis deviation, right ventricular hypertrophy, right bundle branch block, chest X-ray increase pulmonary vasculature, heart involvement. Echo is a diagnostic, management, elective surgical catheter closure. So either we need to close it by surgery, either we need to use catheter. Between 2 to 5 years, though majority require no surgery. Size less than 8 millimeter, likely spontaneous. So always remember, in ASD, size is very important. If the size is less than 8 millimeters, it is going to spontaneously close. I repeat, management is important. So ASD size is less than, they give a scenario, a child with ASD and has a size of less than 8 millimeter. What will happen? It will likely spontaneously close. No need for surgery. VSD. The next thing we are going to read today is the topic called ventricular septal defect. Defect in the formation of the ventricular septum and is the most common congenital heart disease. If the MCQ come like this, what is the most common congenital heart disease? Definitely is the VSD. Alright? Definitely is the VSD. Alright. Now, a small VSD is there and moderate to large VSD is there. So let's talk about the small VSD, that is the majority cases. Clinical features of small VSD. Small VSD, guys. Clinical features include history, asymptomatic, normal growth and development. Very good, because it's small, just like ASD. If it's small, there are no significant clinical features, and the patient is basically, the child is basically asymptomatic, normal growth and normal development. All right, normal growth, normal development, and asymptomatic. Physical examination: early systolic to hollow systolic murmur heard at left lower sternal border. So the murmur here is hollow systolic murmur at the left lower sternal border. ASD, the murmur is, I forgot, guys. Let me look at it again. I don't want to tell you the wrong thing. The murmur is fixed splitting of S2 and pulmonic murmur. It's a pulmonic murmur, fixed splitting of S2. Here there is hollow systolic murmur, best heard at left lower sternal border. Investigations are basically echo to confirm the diagnosis. Management most close spontaneously. Alright, good to know. Then moderate to large VSD, that is moderate to large. Also, it can lead to heart failure, congestive heart failure by 2 months. Late secondary pulmonary hypertension if left untreated. So basically what happens that if there is a secondary pulmonary hypertension, okay, in the late form if left untreated. Clinical features are basically history, delayed growth, decreased exercise tolerance, recurrent upper respiratory tract infections or asthma episodes. So all these things can happen in VST, that there may be because of big size, so maybe heart failure symptoms are there. There may be growth problems, there may be decreased exercise tolerance, and then recurrent upper respiratory tract infection or asthma. So basically VSE has many features, maybe delayed growth, starting from delayed growth, as well as some recurrent upper respiratory tract infection or asthma. Then the physical examination: hollow systolic murmur, lower left side. Always remember this thing: hollow systolic murmur, lower left sternal border. Hollow systolic murmur, lower left sternal border. Hollow systolic murmur, lower left sternal border. Or mid diastolic rumble at apex. Oh no. So what is it we need to remember? Either is a mid diastolic rumble, either is a mid diastolic rumble or a hollow systolic murmur. Size of AC is inversely related to intensity of murmur. Loss of splitting of second heart or loud P2 suggests pulmonary hypertension. There may be features of pulmonary hypertension as well, in which there may be loud P2, maybe loud P2, okay. Okay. Also splitting of second heart sound and loud P2 suggests, so a loud P2 suggests pulmonary hypertension. Loud P2 suggests pulmonary hypertension. This is a hollow systolic murmur, left lower sternal border. Investigations ECG shows basically left ventricular hypertrophy, atrial hypertrophy, right ventricular hypertrophy. Chest X-ray, increased pulmonary vasculature, heart is big in size, heart failure will be there. Echo is the diagnostic, management, treatment of heart failure, and surgical closure by 1 year if surgery required. So basically heart failure, treatment of that, and then surgery if there's a big thing and needs to be closed. Then the next topic we're going to read today is patent ductus arteriosus, a good type of acyanotic heart disease. Patent vessel between the descending aorta and the pulmonary trunk, that is a patent ductus arteriosus. Normally it gets closed within first 15 hours of life. Anatomical closure within first days of life. Functional closure in 15 hours, but anatomical closure within first days of life. So what happens that is a delayed closure of ductus is common in premature infants. If the child is very premature, it can lead to patent ductus arteriosus. Okay, PDA, patent ductus arteriosus is usually associated with immaturity in premature infants, but is typically associated with a functional defect in term infants. Okay, so maybe a functional defect in term infants. Spontaneous closure is less common in term infants. Okay, then the clinical features. History: asymptomatic or have apneic or bradycardia spells. Okay, either the child will suffer from apnea. Apnea is basically cessation of breathing, or bradycardia, decreased heart rate, poor feeding, accessory muscles use, heart failure symptoms. There will be tachycardia, increased heart rate, gallop rhythm, bounding pulses, hyperactive precordium, wide pulse pressure. There is a continuous machinery. Okay, in all the scenarios of PDA, always find for the word continuous machinery murmur. I repeat, guys, repeat after me. All the scenarios of patent ductus arteriosus, the term would be continuous machinery murmur. Continuous machinery murmur equal to PDA. Alright. Investigations include ECG show left atrial enlargement, left ventricular hypertrophy, hypertrophy of the hearts. Then X-ray may show normal to mildly enlarged heart, increased pulmonary vasculature, and prominent pulmonary artery. Management is very very important here. The thing name is endomethacin. The drug name is endomethacin. Endomethacin PDA. Endomethacin PDA. Endomethacin PDA. Antagonizes prostaglandin E2, maintains ductus arteriosus, patency only effective in premature. Okay, indomethacin is basically used for premature. Indomethacin is basically used for premature infants. Catheter or surgical closure if PDA causes respiratory compromise. So we have to put either a catheter, either we have to do the surgery if it causes respiratory compromise. If PDA causes respiratory compromise, failure to thrive persists beyond third month of life, then we have to do catheter or surgical closure. Catheter or surgical closure. Now obstructive lesions. Obstructive lesions basically present with decreased urine output, pallor, cool extremities and poor pulses, shock or sudden collapse. These are very symptomatic. So they can lead to all these symptoms like there will be cool extremities, decreased urine, there may be pulses are poor, and the child can go in sudden shock or sudden collapse. The first thing I'm going to read is coarctation of aorta. Alright, coarctation of aorta, also known as narrowing of aorta. So almost narrowing of aorta happens always at the level of ductus arteriosus, associated with bicuspid aortic valve or the Turner syndrome. Always remember, sometimes it happens in MCQ that they tell us that the case of coarctation of aorta, and they give the scenario of Turner syndrome. Or they either ask that what is congenital heart defect in Turner syndrome. Then we will tick mark coarctation of aorta. Answer is associated with bicuspid aortic valve. Clinical features. Clinical features include basically good history, often asymptomatic. Physical examination including blood pressure, discrepancy between upper and lower extremities, increased suspicion of severity of more than 20 millimeter mercury difference. Very important thing. There is a basically difference in blood pressure between upper limb and the lower limb, and a discrepancy of more than 20 millimeter. That is very important. Diminished or delayed femoral pulses. So diminished or delayed femoral pulses relative to brachial pulses, brachiofemoral delay. Remember, there is a significant difference in the blood pressure between upper limb and the lower limb, as well as there will be brachiofemoral or brachiofemoral delay. Possible systolic murmur, late peak at apex, left axilla and left back. If severe presents with shock in the neonatal period when the ductus arteriosus closes. Investigations include basically ECG shows right ventricular hypertrophy, left ventricular hypertrophy, echo or MRI. Prognosis can be complicated by hypertension associated with other lesion. Management give prostaglandins indomethacin to keep ductal arteriosus patent for stabilization and perform surgical correction units. Older infants and children balloon arterioplasty may be needed. Okay, so indomethacin for the cases of premature infants to basically keep the ductus arteriosus patent for the surgical correction, and for older infants and children balloon arterioplasty may be an alternative to surgical correction. Balloon arterioplasty. Next topic I'm going to cover today is aortic stenosis. Definition: defect that causes narrowing or stiffening of the aortic valve, obstructing the blood flow between the left ventricle and aorta. So aortic stenosis is basically narrowing or stiffening of the valve, aortic valve. Which valve? Aortic valve. And that causes obstruction of blood flow between the left ventricle and aorta. Between the aorta and the left ventricle, if there is a stenosis, that is called aortic stenosis. Four types: valvular, the most common; subvalvular, supravalvular, idiopathic. Okay, next thing is clinical features. History: often asymptomatic, associated with heart failure, exertional chest pain, syncope, or sudden death. Physical examination: systolic ejection murmur, right upper sternal border, aortic ejection click, because it's aortic stenosis, so remember there will be ejection murmur and aortic ejection click. Systolic ejection click, aortic ejection click at the apex. Aortic ejection click or systolic ejection murmur. Investigations: echo. Management: valvular stenosis usually treated with what? Balloon valvuloplasty. Patients with subvalvular supravalvular stenosis requires surgical repair. Exercise restriction is required. So valvular stenosis is associated treated with basically how we need to treat the valvular stenosis. Balloon valvuloplasty. Remember the name, balloon valvuloplasty. Balloon valvuloplasty. And other stenosis requires surgical repair. Exercise restriction is required. Next thing is pulmonary stenosis. Okay, guys, the last topic of acyanotic heart disease is pulmonary stenosis. I understand this is a very dry topic and we always keep forgetting about this stuff. So, my recommendation to you guys is pause the video, focus, try to remember the stuff, and then move forward. Alright? Okay. And keep listening to the video again and again so that the things can get in our memory. I will do the same too. All right, now the pulmonary stenosis, defect that causes narrowing. Stenosis always means narrowing or stiffening. Which valve? Pulmonic valve, obstructing the blood flow between the right ventricle and the pulmonary artery. Just like aortic stenosis, there is pulmonary stenosis, narrowing or stiffening of the pulmonic valve. Was in aortic stenosis was narrowing or stiffening of aortic valve. Now pulmonic valve, and because of pulmonic valve, there is basically decreased blood flow between the right ventricle and the pulmonary artery. So three types are there: valvular, subvalvular, supravalvular. Definition of critical pulmonary stenosis: inadequate pulmonary blood flow dependent on ductus arteriosus for oxygenation, progressive hypoxia, and cyanosis will be there. Natural history may be part of other congenital heart diseases in association with syndromes: congenital rubella syndrome, Noonan syndrome. Clinical features: spectrum from asymptomatic to heart failure, wide split S2 and systolic ejection murmur at left upper sternal border, pulmonary ejection click. So all these are things related to pulmonary ejection click is related to pulmonary stenosis. Okay. Investigation: ECG, right ventricular hypertrophy will be there. And chest X-ray, post-stenotic dilatation of the main pulmonary artery. Echo is the diagnostic. Management, surgical repair, or if okay. So what we need to remember is that VSD, size of VSD is inversely related to the sound of murmur. Inversely related to the sound of murmur. Okay. So we read about coarctation of aorta, aortic stenosis, pulmonary stenosis, PDA, and ventricular septal defect, atrial septal defect, and all these are acyanotic heart diseases. I think I should end the session now. I think that's enough for today, and see you guys soon with the second part of this video, which means cyanotic congenital heart disease. We will discuss about it. Okay, see you soon. Take care.